Jorge.
Jorge, can we hear you? We can. I can't hear him.
Dr. Simon, we will start in 30 seconds. You can start sharing your screen. I'll just give a brief introduction about the program, and then you can start your presentation.
Hear me now?
Yep.
Yes, yeah. Good. Thank you.
Thank you.
This is my phone. I'm bypassing the problem.
Okay. Great.
Professor Orbay, can you share your screen?
It's 12 o'clock.
You see that, Terrence?
Yep.
Thank you.
It's perfect. We start the program, and then we can ask Professor Orbay to share the screen at the final presentation. Good morning, good afternoon, and good evening to one and all who have been here. So this is one of the challenging topic, the volar rim fractures of the distal radius. I said challenging because of the associated complications and not adequate diagnosis and proper treatment to such fractures will always have a post-operative catastrophe. Special thanks to Simon, who has been the brain behind this webinar, who organized well with all legends across the world. We have Professor Brigg, Professor Herzberg, and Professor Orbay joined with us, and Dr. Moni.
And Dr. Marion Bernier.
Moni, yeah. Thanks for joining us. This is a day which is a 34th webinar of the Journal of Hand Microsurgery. The idea behind this program is to teach to our young generations, to our younger surgeons, about the nuances of such challenging fractures. With this brief introduction, I invite Dr. Simon to speak about the volar rim fractures of the distal radius and overview. Simon, I think I have known him for a quite long time, but this is the first time we have met. He is actually a consultant interested more in Kienberg disease, distal radius, advancing images, especially around the wrist. He has been working. He had worked under Professor Bain for a long time, and then he has gained his experience. Now he is working in the Grace Hospital there in New Zealand. Added to his glory, he has a lot of publications, more than 40 publications and chapters, and is a good teacher. And he loves playing sports, golf, and surfing. Thank you, Dr. Simon, for joining us. Please go ahead.
Thank you very much for that very kind introduction. I'd like to thank my fellow speakers today on this really challenging topic of volar rim fractures. So I think really what's interested me is that in the last 20 years or so, there's been indications for wrist fixation defined by multiple papers, and there's been this real explosion in the use of volar locking plate technology. But we have learned that one size does not fit all. And if the volar rim fracture is missed, then the wrist collapses. And in order to best treat these injuries, we really need to fully understand the anatomy of these challenging fractures. So this is work done by Greg, and this is looking really at the fracture lines. So if you look at the fracture lines in an intra-articular distal radius fracture, we know that these occur between the ligaments, and each fragment is therefore likely to have its own ligamentous attachment. So these ligament avulsions create osteo-ligamentous rim fragments, and failure to stabilize these can lead to catastrophic failure of fixation. Physiological extension of the wrist and hyperextension can create tension on these volar radiocarpal ligaments and act as a tension band, and this can lead to an avulsion of the short radiolunate ligament. The other thing that we see is axial compression and shear injuries, and we see these with the higher energy injuries. With further carpal pronation and ulnar deviation, the force can propagate to involve the long radiolunate ligament and the radioscaphocapitate ligament. So we've done some work looking at CT mapping. This is work done with Greg Bain in collaboration. And what's really interesting about these fractures is that when you look at them on CT scan, these aren't just simple rim fractures. These actually propagate, and they can propagate towards the radial side of the wrist. They can propagate dorsally, but they often contain a significant component of the sigmoid notch. And on this little study that we're shortly due to publish, we've identified 4 types. When we look at the management of these injuries, I would recommend a CT scan for every single one of these, and then you can define the different subtype of fracture, which will help you plan management. I think intraoperative fluoroscopy is really, really helpful, and it's important to perform provocation maneuvers on the wrist. I like to put a radial to ulnar deviation force on the wrist and to try and simulate ulnar translocation, and then also a dorsal to volar force to try and see whether the carpus will subluxate. And so you do this once you've fixed the rim fracture to see whether your fixation is adequate. And what you sometimes find in these cases is that you get translocation and then subluxation. So I think it's important to test these intraoperatively. Arthroscopy is really, really useful, and what we're finding is that we're picking up a lot of other injuries. So this is not just a fracture to the rim of the distal radius. This is often a fracture involving the perilunate ligaments associated with TFCC tears. You may see a significant chondral injury. You may pick up loose fragments, particularly in the comminuted injuries. And it also allows you to check the anatomical reduction. And you'll hear more about this later on with the other speakers. So the way I think about these injuries is that these are a spectrum. So this is not just a lunate facet fracture. These involve progressively the metaphysis and then the carpus. So for me, a type 1 is just an isolated lunate facet fracture. Type 2 is where there is radial extension, and this can be an avulsion of the carpus, or it can be osteo-ligamentous, also involving bone. Type 3 is when it propagates to involve the metaphysis. Type 4 for me is a pilon fracture, so this is a high energy injury where there's both volar rim fragments as well as dorsal rim fragments. And type 5 is when it's one component of a greater arc injury. So in terms of the surgical approach, for me, that's defined by the type of fracture. If the lunate facet fracture is an isolated injury, then I prefer a volar ulnar approach, and this allows direct access to the lunate facet. We then proceed with a fragment-specific fixation to contain the fragment. But if the lunate facet fracture is one component of a distal radius fracture that propagates either radially or towards the metaphysis, then I would prefer an extended distal FCR approach with oblique extension across the wrist crease. And this allows you really good ulnar to radial exposure to try and deal with the smaller capsular avulsions up towards the radius. So a volar ulnar approach, you make your incision between the FCU and the palmaris longus. You move the flexor tendons and the median nerve towards the radial side. You move the ulnar neurovascular bundle towards the ulnar side. You can then extend it distally if you need to perform a carpal tunnel decompression at the same sitting, and this is often the case with high energy injuries. I then use a needle often to identify the joint. I release pronator quadratus and then use fine joysticks to help, fine KYs as joysticks to help reduce the fracture and temporarily fix it. You can then use a small containment type plate to try and hold the fragment, but you may also need supplementary fixation, particularly if there's a large capsular injury. So in terms of looking at fixation techniques, if it's a type 1 fracture and it's an isolated lunate facet fracture, this is a short radiolunate ligament avulsion, and you need to use fragment-specific fixation. And often these buttress pins are quite helpful just to contain that small fragment. It's important not to comminute the fragment, and therefore this type of fixation is often quite useful. In a type 2 injury, for me, this is where you've got propagation radialwards, and this may just be very small osteo-ligamentous avulsions, or maybe a large capsular sheet, such as in this case. And in this case, I would use fixation at the lunate facet and then a trans-osseous type repair, either through drill holes or using all suture anchors. Type 3 is when you've got propagation towards the metaphysis. I'm sure you hear about this from Professor Orbay. I particularly like the Geminis plate for this fixation because you can fix the metaphyseal part of the fracture, particularly if there's also a radial styloid component. But then you have a hook plate extension, which is really useful to capture this rim. And so you use a guide, you sit the guide on the volar rim, you then transfix it, and then you sequentially remove the wires and you fixate it with the plate, which then screws in. And I've found this to be very useful, and also in fractures of the metaphysis where you're not too sure whether there's a separate rim component or not. The type 4 injury for me is a pilon type fracture. So not only do you have a volar rim fragment, you've also got a dorsal rim fragment, and you may have a styloid fragment. And for me, in this case, this is where bridge plating becomes incredibly useful, because what you want to do is you want to hold these very small rim fragments, but you want to neutralize and protect your fixation. So I use just a standard metaphyseal plate with the thin end towards the metacarpal. You can then transfix it to the third or the second metacarpal. You can use this instead of a cast at the end, and it just neutralizes the fixation of the very small rim fragments. This is also useful in the setting of damage control orthopedics when you want to use fixation quickly. Type 5 is when it's a component of a greater arc injury. So this is an example of a trans-styloid, trans-scaphoid, trans-ulnar styloid fracture in a patient who fell whilst rock climbing. So this is when you have both the short radiolunate ligament injury, but a much greater injury to the carpus as well. In this case, I proceeded with fixation of the intermediate column. It was a relatively large rim fragment, so I could hold it with the buttress plate. And then fixation of the radial styloid. So fixation of the radial column with a styloid specific plate. Antegrade screw fixation of the scaphoid, and then a tension band fixation of the ulnar styloid with suture and KYs. But really, this injury is just the tip of the iceberg, and we published earlier in the year a comparison of 25 of these volar rim fractures versus controls. And as we all know, and as the other speakers will talk about, there's a very high rate of complications. And so really, this is the tip of the iceberg when you see this injury, and there's often a much higher rate of other carpal injuries, scapholunate diastasis, and postoperative ulnar translocation. So I think in summary, careful review of the preoperative imaging is really essential, and CT scan is imperative in all of these cases. These are really complex injuries, multiple ligaments are involved, multiple osteo-ligamentous avulsions, and multiple joints are involved. Consider your surgical approach carefully. So if this is an isolated lunate facet fracture, I would favor a volar ulnar approach. But if it's a more global injury to the distal radius, then I'd do an extended FCR approach. But consider the soft tissues, because this is not just a bony injury. It's important to stabilize the ligaments and stabilize the carpus. Consider the fixation. There's a number of different techniques and different plates and devices available, but I think it's important to go into these cases with 2 or 3 options. And for me, I always go in with a bridge plate, because my theory is you want to stabilize and neutralize, and often these are high energy injuries. And if you have a very small rim fragment just being contained by a small plate just distal to the watershed line, it's often very important to neutralize and protect the fixation of that very important fragment. Consider arthroscopy. So this is an example of a case where I use dry arthroscopy. And this is just simply using a needle with suction attached to the needle. And what that can do is just suck out the clot and allow you to see the fracture line. This is just using a Fraser sucker through the 6R portal. And post-reduction, you can go in. I'd normally do this dry. And you can pick up other injuries. There's a central TFCC tear there, which is chronic. But interestingly, although we gained what we thought was a perfect reduction, you can see there's still a chondral step. And so you can get a chondral injury, which you wouldn't otherwise appreciate. And so I think for an extra 5 or 10 minutes of putting an arthroscope in, I think it gives you a lot of information. So I think about these injuries as a classification with 5 different subtypes. And this is just my own observation. 1 is an isolated volar ulnar corner. 2 is when there's radial extension. 3 is when there's extension proximally towards metaphysis. And 4 is when it's one component of a pilon fracture. And 5 is when the fracture is the component of a greater arc injury. And that's what I base my management plan on. Many thanks.
Thank you, Dr. Simon, for this incredible talk, especially on the classifications. I think which is really useful, especially the management's concern. So we have a lot of questions, and we'll take the questions at the end. Now, may I invite Professor Greg Bain.
Can you allow me to share, please?
Yeah, I'm doing that.
Sure.
Thank you.
I was actually speaking to one of your PhD researcher, Melanie, about Professor Greg. So she wrote me 2 pages of you, and I was amazed to read all those facts about you. I said he's a legend. That much I can introduce him to the speakers, because everybody knew about Professor Greg. He has been the deputy editor. He has received many awards, especially in the American Society of Hand Surgery, and he has trained many surgeons across many different countries. A lot of chapters in the books, articles, and so on, so on. Thank you, Professor, for joining us. Please go ahead.
Thank you very much for those very kind words. Thank you for Simon for organising this. I think this is a really fantastic symposium with world-class speakers, so thank you for having me involved. So we're going to talk about volar facet fractures, including those specifically with regard to the osteo-ligamentous concepts. So when we look at the ulnar side of the distal radius, we can see that this is what we refer to as the calcar of the radius, and this is corresponds to a thickened area on the volar ulnar aspect of the distal radius. And this is the area that takes a lot of the load from the lunate facet, but also from the distal ulnar. And it's not surprising that this critical zone, which is at risk when we have fractures in this area. The watershed line.
Sorry to disturb you. Can you share the screen, please?
Okay, am I not sharing?
Yeah.
Would you like me to start again?
Yeah, please.
Sorry, I thought we were on. Okay, so osteo-ligamentous fractures and the osteo-ligamentous unit concept for volar facet fractures. So if we have a look at the distal radius, we can see that there's a calcar on the ulnar aspect of the distal radius, which takes the load from the lunate facet and from the distal ulnar and transmits this load down through to the shaft of the radius. It's interesting to note that there is this thickened volar aspect of the cortex, which is the critical aspect for taking this load. And of course, this is the area that we're talking about today. Orbay has taught all of us about the watershed line. I think it's time to change the name. It's really a ridge. They described it as a ridge, and it's even described with regard to being the watershed is a concept of how the rain will go down and fall down on one side of the ridge and go to a catchment to one side or the other. So it is a ridge in clinical practice, and it is a ridge in concept, and it's even described as being an imaginary line. I think it's time to call it the watershed ridge, and everything distal to it is the attachment of the volar carpal ligament. Everything proximal is the pronator quadratus, and really it's a tubercle or tuberosity that's designed to be able to increase the mechanical advantage of the volar capsular structures. We were involved with a study some years ago, which I think is an important contribution, looking at the distal different types of fractures, the distal radius, and what we found was the majority of the fractures occurred between the ligaments. And this was important because it identified that each of these fragments would then have an associated ligament attached to them. And we developed this concept of the osteo-ligamentous units, and that these were the primary fragments with the radial styloid, dorsal ulnar, and volar ulnar aspect. And so pretty well all of the fractures that we see in clinical practice come as a consequence of these primary aspects of the distal radius. And then there's these secondary aspects, which are really just a combination of two of the other aspects of the distal radius. So if a patient comes in and they have a fracture of the lunate facet, it's related to an extension of the wrist, tension on this ligament, and the force goes down through the volar aspect of the lunate facet. And that this is the osteo-ligamentous unit. So it's a fracture of the distal radius, the associated ligament, and the ligament goes to the other side. It goes to the lunate in this case. So the short radiolunate ligament and the radial style and the volar aspect of the radius together forms an osteo-ligamentous unit. If we see this example of the wrist going into ulnar deviation, we can see how the lunate will punch in through here, through the volar aspect, and keep intact the short radiolunate ligament. We create this die punch concept in some cases, and there will be impaction of the bone below that. So when we look at this concept of a fracture, this is a separate unit which is all defined together, and we need to respect that. So it's not a concept of fragment specific, but it's a concept of osteo-ligamentous units and being specific on the treatment and respecting each of those osteo-ligamentous units. So these are the primary units that we're aware of, and as they move apart, but also as we try and bring them together, we try and identify what those fracture fragments are and the associated ligaments. This is a fundamental concept of all articular fractures. It's not specific to the wrist. It occurs in the elbow, in the shoulder, ankles, and all other intra-articular fractures in the body. Simon's already referred to, in principle, this concept of this mapping study we've recently been conducting. And we can see here how in each of the examples, this volar lunate facet is related to the short radiolunate ligament. And interestingly, it is the smaller fractures that are much more dangerous. We can see here there's much greater instability with this smaller fragment. Another interesting observation is that these smaller fragments will tend to rotate around. They actually pronate around the TFC structure and provide that type of instability. If we look at this particular example, we can see this volar facet, and we can see how the ligaments protecting and stabilizing the scaphoid are no longer having the stability of the scaphoid. So if we put the ligaments in position, we can see how the radioscaphocapitate ligament must be violated in this type of injury. And probably also the long radiolunate ligament, which may predispose to ulnar translocation. So this is an isolated volar facet fracture, but yet the scaphoid facet is intact with regard to the bone, but there's an occult ligament injury. This is a very important concept and one we need to understand and respect. This is a study which we've published this year in the Journal of Wrist Surgery, looking at marginal volar rim fractures, and we identified a high association of volar instability, scaphoid instability, distal radial ulnar joint, and ulnar translocation. So instabilities are a real problem. Failure of fixation and the need for revision surgery was not uncommon. And some of the failures here, this is a failure of the plate to capture this distal fragment. And this here, we're failing to contain the ulnar aspect of the distal radius. This is a secondary collapse with ulnar translocation, which we think may be due to violation of this ligament at the time of surgery, but we can see how this is developed over a few weeks. This is not part of this study, but as an example of a case that presented to us, I saw the patient at 2 weeks. The general practitioner had performed a CT scan, and we can see how the lunate at the initial presentation was lined up in a reasonable position, but with time, the inclination of the distal radius is increased. There's reabsorption of this bone, and after 5 weeks, this had actually healed and didn't require surgery, but clearly we were concerned that with the counterleavering effect here, that this may go ahead and cause further fracture. This gives us an insight as to the concept of secondary collapse of some of these fractures. The other interesting aspect is the edema of the distal radius, the regional hyperemia, and the regional osteoporosis that occurs with distal radius fractures. I want to go on and share with you another case. This is not a volar fragment of the volar facet, but of a radial styloid fracture. And we can see in this young man how we've got this radial styloid fracture here. We've got the volar ligaments attached, and there's this large rent that goes all the way across, creating this, what we refer to as a sleeper lesion of the within the wrist. And so if we look at this, this is a lesion we need to identify and predict it, but it's where there's one of the stabilizing structures that may become unstable with further loading. So there's a significant injury, and I think it's just the secondary restraints that are holding it in position. There is an at-risk injuries are those with high energy injuries with lots of swelling, and we need to look in detail at a CT scan. Is there any fine avulsion injuries that we can see? Is there subluxation? Maybe an MRI scan to look at the ligaments, stress radiographs, and arthroscopy, I think, can be important in some of these cases. And I think there are some common concepts with regard to Guillaume's work on the Plind lesion, and he may wish to comment on that a bit later. He's done some excellent work in that area. So the volar rim fractures, basically it's an impaction fracture down onto the volar aspect of the distal radius, leading to this volar subluxation of the carpus. There may be secondary scaphoid instability or distal radial ulnar joint instability, but the other thing we need to be careful of are these sleeper lesions, which are come across here and lead to secondary problems such as ulnar translocation. We know that the ligaments are intact. The concept of ligament ataxis is not new. We've been using it for 100 years. The ligaments remain attached, but as that comes out to length, we can see how this doesn't cause a true anatomic reduction, but it does help with regard to some of the reduction of the fracture. When we are performing an exposure of this articulation, we need to go proximal to this fracture, elevate it up on the ligaments, and then get an access to the articulation, and then close it down so that we don't violate these ligaments. So with regard to stabilizing these fractures, there have been many types of fixation that have been described. And I think most of them we're aware of with regard to buttress plating and bridging plating. But I want to share with you the concept. I think this is not buttress plating. This is more of a containment plating that goes around and holds together and contains that distal radius. And then this is different as well. This is not a buttress plate. This is capturing or hooking that distal fragment and pulling it down. These are fundamentally different concepts. So there's a number of things we need to talk about with stabilizing this fracture and preventing this complication. So we can use K-wires and things or screws here, but we need to respect this fracture, maybe put a suture in there and put the plate over the top or using a hook. But we need to respect and understand these fracture fragments. So this video here, we can see the lunate, we can see the distal radius fracture. And as we bring this distal radius fracture back and reduce it in position, we can see that all these ligaments remain attached to the distal radius. And as we bring it back into position, we can see that no fracture fragments fall out of the wrist. But it's amazing how hard it is to reduce some of these fractures when it looks so easy in this cadaveric model. But we can see how these ligaments remain attached despite this. So the osteo-ligamentous concept is the fractures are involved with creating the injury. The ligaments remain attached. They determine the settling position, the contracture, and it can be stiff and unstable. So in summary, we need to respect the anatomy. We need to understand the osteo-ligamentous units, and we need to be able to apply these to our treatment algorithms to get the best outcomes for our patients. Thank you for having me involved.
Thank you, Professor Greg, for this incredible talk on the osteo-ligamentous concept. And it's really amazing, and a lot of new concept have emerged. Like you said, the sleeper lesions and the hook concept, and also the construct concept. I think thank you for this wonderful talk. May I invite Professor Herzberg to talk on his topic.
Yes. Can we share? We don't have the.
Could we allow us to share the presentation, please?
Let me do that.
Okay, thank you. Can you see the presentation?
Yeah, perfect.
And can you hear us?
Yeah, thanks, Professor Herzberg and Marion Bernier for joining us. Couple of words about Professor Herzberg. I think most of us knew him well for his concept in wrist arthroscopy and distal radius surgery. He is currently the head of the professor department in the University Hospital in Lyon, France. He has been closely associated with the Journal of Wrist Surgery, and he has pioneered a lot of works in wrist arthroscopy, especially in distal radius fractures. Along with Dr. Marion Bernier, it's really an honor for us to have you both today at this special webinar on distal radius Volar fractures. Thank you again. Please go ahead.
Thank you very much for the introduction. Marion Bernier.
Herzberg.
Marion Bernier has been one of the brightest residents I've ever worked with, and the brightest fellow. And I'm happy to share a lot of scientific work with her right now. So we will talk about what was alluded to before by the previous speakers, which is what's the use of arthroscopy for those complex fractures.
First of all, we will remind, of course, the small step of the wrist arthroscopy. We used to start with the 3-4 and MCU portal, and with the first exploration, and then we performed the 6R, and after that the mid-carpal, radial mid-carpal portal. The last one so will be the MCR, as you can see.
And it's amazing. You see here we use the automatic washout. It's amazing how in about 30 seconds or less you can see so many things into the wrist. If you use the automatic washout technique, which is a variant of Paco's penal dry arthroscopy technique, you will discover things. And the beauty is that you just discover what Greg Bain was alluded to previously, which are the bony injuries and the ligamentous lesions.
And with the automatic washout, you can remain dry, which is especially useful for the distal radius fracture. One more thing about arthroscopy in the fracture is that you can, of course, assess and reduce the step off on the gap, but as mentioned previously, remove loose bodies, and finally to diagnose and treat the ligamentous tears, just like TFCC or scapholunate tears.
So it's surprising that there are very few reports about the use of arthroscopy in B fractures. And we wrote very early, about 10 years ago, that a B fracture was a transitional form to a fracture dislocation. If you think of this, it's very clear. The B3 fractures are a variant of radiocarpal volar dislocation, and the B2 is a dorsal dislocation.
And in this series, in the studies we made in the unit, we reported that considering the C fracture, there was a significant better reduction of the radiocarpal gap and step-off if we use arthroscopy. So that should be the same, of course, for the B fracture.
We don't have such a sophisticated classification, but Dr. MacLean classification is very useful. But we just separate them into two types. This one is more radial, and there is no really, like in this example, there is no really tendency to volar dislocation because the medial facet and the short radiolunate ligament are basically intact. And if you use arthroscopy, you can find with a limited approach, you can find the step off and reduce it very, very, very nicely, and actually use a very tiny fixation for a difficult fracture with a very, very anatomic result. We are talking today more about the medial facet fracture. Why, Mario?
Because we know that this volar medial facet is important to maintain, as showed previously, the stability of the radiocarpal joint. And as beautifully mentioned by Dr. Bain previously today and in our ITRUS meeting few days ago, of course, it's a big area of interest because there is some insertion of the major extrinsic ligament, like the short radiolunate ligament. So we have to not only reduce, but have a strong and stable fixation of this volar medial fragment.
And again, as previously mentioned, if you don't pay attention to that, you can get catastrophic follow-ups, like here or here.
Yes, but look, here in those examples at the beginning, it looks like the plate really reach this volar medial fragment.
Yes, but the answer is that it's just impossible. It's just impossible to get to the LVR, the lunate volar ring fragments, through a classic Henry approach. It's not completely impossible, but you have to push very, very far away the flexor tendon mass.
And especially because in B fracture, it's usually young patients, and some of them are like muscular, and they make a fall with a high energy, so you have some edema. And yes, we all know this situation in which, okay, we have this volar fragment, and we try to reach it. You ask your assistant to pull on the tendon, but you know there is also the medial nerve, so you can either make a larger approach.
You tell your assistant, pull and show me, pull and show me. And he said, what can I do? It's just impossible. Of course, we all know the wonderful teaching of Jorge. And thanks to Jorge, he provided to the whole world a way to cope with this approach, to enlarge it and to see everything. The only question is that it's not just possible using arthroscopy, because with the traction, it's impossible to combine a Jorge approach and traction, because of course you tension the flexor tendon mass and it obscures completely the most medial part of the radius. So
that's why we think interesting to share with you this combined approach from the usual and rare approach. You can reach either the radial, but also with a medial window between the flexor tendons and the ulnar pedicle, you can reach the volar rim. So this was described by Dr. Olivier Marais a few years ago.
From Nîmes in
Yes.
France. We know him very well.
Oh, sorry. And as you can see here, through the usual Henry approach, you can make a little bit more distal incision or even keep this one. And you can go to the usual, aspect of the distal radius, but by going between the flexor tendons and the ulnar pedicule, just under the skin. So just pay attention to the cutaneous branch of the median nerve, and then you can reach the volar rim situation of the distal radius.
You are just in front of it, even if you are under traction.
And this is the example with traction, as you mentioned. And this is the example because sometimes you have a combined fracture for which you have to fix both the radial and the ulnar portion of the distal radius, but you have to go really more distal, as shown in some example, and to fix even with an isolated screw. And as you made it in this patient with the traction, we can, with this specific approach, go directly to the fracture to fix it with an isolated screw.
And put a specific screw beyond the plate and beyond the watershed ridge.
To avoid this volar dislocation that unfortunately you can see in some patients. And look at the aspect of the wrist at the end. You don't have so much edema, and the wrist looks fine. In our experience, 10 years of follow-up in the unit, you can see that we reported 50 type B fracture. And in those 50 fracture, we had 14 B3. Here, there is only 6 dual window approach, but I think that now if we will, make surgery on those patients, we will use for, I believe, maybe most of them or maybe all of them, the dual window approach.
We still have to admit that it's not a very frequent indication, but you have to have it in your armamentarium because it's very, very useful. So now we have two cases. So please think of this case, Marion.
Yes.
Maybe.
As you can see, he's a young man, white collar. He's already 40, cycling, skiing. He has high functional needs, what we call PAF PIF 3-3. This is a classification, describing the patient, the accident, and the fracture. So this patient has high functional need and no comorbidities. This is the fracture that you can see, and of course this articular fracture. We have some video, the sagittal view, showing this volar rim fracture displays.
And already a volar subluxation of the carpus.
Yes, so you have something to do for this patient, of course. And we will let you, just have a look to this and maybe think about what you will do, especially the approach as we discussed, and but also the type of fixation.
The question being, would you use arthroscopy or not arthroscopy? And actually, it was very useful in this case to use arthroscopy. Look how you can reduce the cartilage, which is something. It's possible to do it open, of course, but it's much more devastating in terms of crossing more normal structures, and you can have a very, very good fixation using the Marais approach. Again, putting the screw, the last screw, really very distal and medial. With of course, it's a difficult injury, so it's not a perfect result, but at least it's acceptable clinically. And radiologically, you have all the criteria of normal radius and carpal.
With no ulnar translocation, which is like devastating for patient, as we know.
With no ulnar translocation. Thank you for pointing this out again.
Another case? Maybe?
Another one, please.
Yeah. So this is, as you can see, a radiologist. So of course, again, high functional need patient. It is his left non-dominant wrist. You know, you probably also have electric scooter, and you know that this is really painful if unfortunately you fell from them. So pay attention. You can see this Volar fragment. One more time, some CT scan view, and okay, just, you know, as we said, of course you can imagine that there is some ligament to attach there, and you have to fix this fracture. You can see the gap and the step off.
We see exactly the pronation effect that
exactly.
Bain was talking about before.
Yeah, good point. And so one more time, just few seconds to think about your approach. Would you use only ulnar Volar approach or combine? And what we did?
We chose a single ulnar approach in between the flexor tendon mass and the ulnar pedicle. This is the fracture line and step off. This is the provisional reduction. This is the automatic washout technique, and you find incidentally that there is a small injury of the TFCC of the disc, and that the reduction is just perfect or close to perfect. It's not
acceptable.
It's acceptable, and then you can fix it just with there are specific plates for this, but in this case we chose, because the bone was very good, we chose only screws with an anatomic result. Do you have any post-op CT, Marion?
Yes, I think we do. This is the post-op CT scan, because we like to check that our reduction in articular fracture are correct and to follow it. And he's a radiologist, so he wanted this post-operative CT scan, of course. So you can see that, of course, you don't need, because we had some question about that, you don't need to see or the distal radioulnar joint, because there is only one fragment. And of course, if you fix it appropriately, and you can see both on the Volar part and on the articular side that the reduction is correct, your DRUG will be fine.
And you showed this in your thesis, and in the article, there was a difference at the radiocarpal level, but not at the the DRUG level, irrespective of the fact that you use arthroscopy or no arthroscopy.
Yes. In summary,
please summarize.
Thank you. We can say that okay, this approach can be really useful in the B-type fracture. Of course, you have the ulnar approach, but this double approach, especially if you are using arthroscopy, and we know that arthroscopy is particularly useful in this fracture. So feel free to use it, and after an appropriate workup with a good CT scan view and 3D reconstruction. Thank you.
So it should be an incentive to use arthroscopy and use this special approach to make things easy.
Thank you very much. And of course, you are welcome in our next meeting in Lyon, but like more virtually in 1 week on Monday for the wrist and Tuesday for the elbow. Thank you very much.
Thank you.
Thank you. Thank you very much, Professor Herzberg and Marion Bernier. I think almost everybody enjoyed your interactive way of discussing the cases, and of course, it's the first time I saw a professor with the brightest student who are presenting both together their work and sharing the experiences. I think really everybody enjoyed and loved watching this program and your talk. Thank you very much for this interesting talk.
Thank you.
We have the special speaker, Professor Orbay, because it's exactly 4 a.m. in the morning, and the special thanks and our sincere appreciation to Professor Orbay that he could, spare his time, speak, especially for this webinar. And it's really very thankful for him to joining at this, very odd time. Professor Orbay, I think everybody knows about his surgical approach and his contribution towards the wrist arthroscopy, wrist surgery, and distal radius. He's also one of the legend in this field. Thank you, Professor Orbay, for joining us, especially at this odd hour. And we will make you as a presenter and start sharing your screen.
Thank you, Terrence. It is a privilege and an honor for me to be sharing with all of you today. And I'm going to speak about stabilizing the volar ring fracture and the techniques for salvage procedures. So this is my disclosure. This was a great contribution by the Australian team on how these fractures propagate. Well, the most common fracture line is the one that starts or finishes at the sigmoid notch and communicates all the way down to the interfossal sulcus, creating or the volar medial fragment. Now, to understand the biomechanics of this injury, we must know that the forces are applied on each fossa different. On the scaphoid fossa, the center of force application is basically in the geometric center of the fossa itself. While on the lunate fossa, the centroid of force application is all the way palmar on the lunate fossa. Now, the microanatomy of the distal radius, as also the wonderful Australian team has shown, is that on the scaphoid fossa has two well-developed columns of metaphyseal bone supporting the subchondral plate, while the lunate fossa has only one. And why is that? That is because of the forces are applied particularly in those areas. This is just the Wolff's law, and bone is deposited where it's necessary. The problem is if we have a fracture, and considering the patterns that commonly occur, the lunate fossa is at risk because the force is applied on the volar fragment that is offset from the support of the shaft. That's why the volar lunate fragment is considered the keystone of the wrist. A little more about how the biomechanics occur. The lunate loads on the articular surface after reduction. The volar lunate fragment acts like an inclined plane, generating a force vector that is directed palmarly. Normally, this is supported by the volar buttressing surface of the plate, which is usually all you need in the typical fracture. But there's a limit to how much we can buttress volar lunate fragments because the flexor tendons come in contact with the bone at the watershed line. Whether it's a line or a ridge, it doesn't matter. But we called it a line 20 years ago, so let's keep it a line. That line is 3 millimeters from the articular surface. And you cannot apply all the a plate at all the way distal to the watershed line because it would be protruding above the horizon and injuring the flexor tendons. So you have to apply your plate, say 2 millimeters proximal to the line. That means that any volar lunate fragment that is less than 5 millimeters long has absolutely no support whatsoever. Well, even if it's 7 or 8 millimeters, it still has very limited support. And these fragments that fail to be supported by a volar plate is what we call a volar marginal fragment because they fall off and the whole carpus follows that little fragment And these are disastrous cases that are very difficult to salvage. Well, the volar lunate fragment, or the volar marginal fragment, can be considered also as primary. Those that you identify in fractures that have not yet been fixed. And this is the only time you can assure a great result. This is a dorsally displaced fracture. It's a high energy fracture, but it has a volar marginal fragment. Why? Because if you look at the volar lunate fragment, it's really very short. It's about 4 millimeters long. So this one is going to be a problem. You can identify these fractures preoperatively. At this time, we have achieved what we are very satisfied with is an anatomical reduction, but we notice that the volar lunate fragment is distal to the distal edge of the plate. This is a recipe for disaster unless we do something. Now we have the hook plate, which is, if you may, a fragment-specific extension of the volar plate. Here is the lateral view in fluoroscopy when we are providing temporary fixed angle fixation by means of K-wires. Notice that the fracture is just at the distal edge of the plate. The solution is a hook plate, and it's a very stable form of fixation. Volar marginal fragments can also be considered when they already have had surgery. The failed volar lunate fragment is a really big problem. And we like to consider them depending on the time that has occurred since failure. If it's less than 4 weeks, we call them acute. If it's between 4 weeks and 4 months, we call them subacute because the bony changes are not very developed. But if they are more than 4 months, we call them delayed. And these cases, unfortunately, many times have already extensive cartilage damage and are very difficult to treat. This is the natural history of a volar marginal fragment. Dorsal fracture treated with a volar plate. By the lateral view, you can tell that there was something going on during the case. We saw that there was a volar marginal fragment. We tried to stabilize it. This is a long time ago before the hook plate with a tension band, small metallic monofilament tension band. Our fragment was comminuted. There was a very small tip fragment. And about 4 weeks afterwards, that little tip fragment had already migrated to the other side of the buttressing surface. And the larger volar marginal fragment had already started to collapse. By 4 months, we had this degree of collapse, and the plate was creating a cavity on the lunate. For the acute cases, be less than a month, maybe you can get away by refixing them if they were really fixed improperly. The subacute ones, the ones between 4 and 16 months, you cannot just fix them again. They always fail. You have to unload the wrist somehow to neutralize the forces on the volar lunate fragment. And we like to use a spanning plate for that purpose if the fracture has not healed yet. And if the fracture is already healed with excessive volar tilt, we then perform an volar opening wedge osteotomy. And when the fracture is delayed several months and there's irreversible articular change, we perform a salvage operation, usually some sort of fusion. Fixation options for acute fractures are buttressing. Some plates are designed as pure buttress plates. They must be removed because the flexor tendons come in contact with that plate. We can use K-wires. I used to use K-wires and let them long on the dorsal side so I could remove them later. Tension band, wire forms, fragment specific. Lag screws that abut against a volar plate are also a useful method of fixation. And now we have the hook plates. Our group presented our experience with dealing with volar marginal fragments, acute and delayed. And what we found was of 18 acute volar marginal fragments. And that means those that have not been operated before, we got them all to heal. Of the delayed ones, the ones that had been treated but fell apart, but that were less than 4 weeks, we only got 50% healed. Those that were between 1 and 4 months, we unload them with a a bridge plate, or sometimes we combine techniques. In this case, we pin the lunate to the radius in order to further unload it. Or if the fracture is healed already, but it's still salvageable, we like to do a volar opening wedge osteotomy. This is the case that I showed you before that has fully collapsed. And in this case, we did a volar opening wedge osteotomy successfully. The idea is to create a dorsal deformity, at least decrease volar tilt to 0, so the forces are not directed to the volar aspect of the lunate fossa more dorsally. Arthrodesis is total arthrodesis is a viable option, but partial arthrodesis, like a radioscaphoid lunate fusion with resection of the distal pole, is our favorite method when saving the articular surface is not possible. And finally, let me show you one case. This is a 59-year-old lady fell while rollerblading, and she was treated by a well-meaning surgeon, but unfortunately, the initial reduction was not really that hot, and by 18 weeks, it had complete collapse. So what do we find in these cases? The first thing we find is that there's a lot of bone reabsorption, particularly of the volar marginal fragment, to the point that only subchondral plate and cartilage is left. But we think that in many of these cases, we can save it. So we harvest bone from iliac crest or a proximal ulna, in this case, proximal ulna if the patient is ambulatory. We fill the defect with bone graft. And you can see in the fluoroscopy, the still intact subchondral plate and now being supported by cancellous bone graft. But notice the excessive volar tilt. That's because the remainder of the fracture has healed with excessive volar tilt. That redirects all the forces palmarly, and that's going to probably induce a failure of our treatment. So what we are doing in these cases is we are creating an opening wedge osteotomy. We drill a K-wire parallel to the bone, cut parallel to the K-wire, open the osteotomy, and pack some allograft just to hold it in the open position until we evaluate under fluoro and confirm that we have eliminated volar tilt. This way, the joint reaction force is no longer in the volar marginal fragment, but it's shared by the rest of the articular surface. The plate must be adjusted to the deformity we're inducing, and this is the immediate post-op. The intra-op, packing bone graft to the opening wedge, the first post-op X-ray, and 2.5 years later, this certainly does not look like a normal radius, but she healed, she maintained motion at the radiocarpal joint, and she has a rather satisfactory result for such a terrible situation. So in conclusion is be vigilant for these volar marginal fragments, identify them and treat them early, because only the first time can you get the excellent result that the patients deserve. But if you have to treat a failed volar marginal fragment, consider unloading the joint by using a bridge plate or performing a volar opening wedge osteotomy if the remainder of the fracture has already healed with deformity, or perform a salvage procedure if necessary. That's all I have. Thank you very much.
Thank you very much, Professor Orbay, for your interesting talk, explaining the problem. Primarily, the surgeon should have a suspicion primarily, and then to involve that segment of distal volar rim less than 4 millimeter, that should be incorporated into the plate either by a hook or, as you mentioned, simply by occasional wire or a tension band wiring. I think that is the crux in diagnosing primarily. Also, your salvage procedures, it's after 16 weeks, and your cases is also quite amazing. Thank you very much for this incredible talk. We have a couple of questions to all the panelists, and then probably we can take other questions, if possible, through emails, considering the time limit. The question which I received is to all the panelists. In the salvage procedure, as you mentioned about the salvage procedure, does the radiolunate fusion alone can be one of the salvage procedure, especially in a failed or late presentation of more than 4 months?
Let me handle that because this is what I just said. The simple radiolunate fusion, when applicable, it's a great option. Many times the fracture involves more than just the lunate fossa, and in those cases it might not be possible. But I find the radiolunate fusion to be a very functional arthrodesis.
The issue is the radiolunate fusion usually performed from dorsal, and so can you explain the combination of the volar injury, the dorsal approach? Or how do you deal with the combined approaches if you use them?
Radiolunate fusion, when you have a failed volar marginal fragment, but the rest of the articular surface is intact, and this occurs in those more simple fractures, which really only involve the volar lunate facet, and they heal with malunion. The patient develops a shortening, and their main problem is usually the lack of forearm rotation because they develop a ulnocarpal impingement. In those cases, when you cannot osteotomize and lift up the lunate, and a fusion is a viable option. The fusion is usually done from the dorsal side, and it might be necessary to go dorsal in these cases and not volar, particularly in the neglected cases that never had an operation from volar side. You can just go ahead, do a dorsal incision, and you must lift the lunate because part of the problem is correcting the ulnocarpal impingement. So you have to somehow get the lunate back to length, or the alternative is to perform an ulnar shortening procedure.
Thank you.
Thank you.
I was just going to say, in my experience, the salvage procedures I've done, the fractures involved, the scaphoid facet as well, and I favoured a radioscapholunate fusion. But I think the other thing to think about is the distal radial ulnar joint in these cases, because if you have a malunion or non-union of the lunate facet and it's a large fragment, then often they have associated arthritis of the distal radial ulnar joint, and you might be looking to perform a salvage procedure. So I think you need to also bear that in mind as well.
Thank you very much. The other question is about the osteo-ligamentous constrictor, osteo-ligamentous in treatment. The other question to all the panelists from the participant is that which ligament or which capsule you need to be enforced during the repair. If at all you need to repair the ligament or capsule, which ligament you need to repair, or which you think you need to augment once you feel the fixation is okay, because it's not the bone alone, or it's not the ligament alone. It's something complex involving the bone and the ligament.
So first of all, I'm really pleased to see the way you've put that and the way the question comes. It's not just a fracture, and it's not just a ligament injury. It involves the ligament and the bone. And in fact, my whole message is about trying to get better at the assessment and understand what's actually happening with these injuries, whether it's a lunate facet, involves a short radiolunate ligament, or there's that extension around to involve the long radiolunate ligament or the radioscaphocapitate ligament. So my whole message is to try and understand that. And the thing that we can do with surgery is really look at our CT scans in a bit more detail to try and predict where they are. At surgery, if we do the arthroscopy, we can visualize those ligaments. For those surgeons who aren't comfortable with doing the arthroscopy, or they don't have that in their facility, they can still do stress views. So you can do a traction view or a ulnar translocation or volar translation, and try and get an understanding of exactly the type of instability you've got. And then the other thing is, all these complex injuries, once you fix the radius, you must assess the stability of the distal radioulnar joint. So a lot of these very bad injuries, the distal radioulnar joints been involved. So that's my main message, and try and understand it and respect that whole complex.
Thank you very much. A lot of questions from the attendees and participants to this webinar. Considering the time limit, we will take all those questions and probably send to the email, and we can get them replied to those participants. So we have quick closing remarks from all the panelists here. Quick 30-second closing remarks.
It's been a really, really interesting set of talks. I think each talk has brought a different slant on this very challenging topic. I certainly find these fractures very tricky to fix. And I've certainly had a better understanding from listening to the other speakers talk.
Yes, I agree with Simon. It's really been a great pleasure to be involved in this. We've got such a wonderful spectrum here. Simon's given us an overview of some of the types of fractures and that classification. I've tried to cover the osteo-ligamentous units and how to apply that, and maybe think about the way that we're using the plates a bit differently. Guillaume's given us a wonderful perspective on how arthroscopy can be used, and Orbay really revolutionised the whole internal fixation of all distal radius fractures, and then his overview of these complex revision cases, I think, is a real insight to how to manage these very difficult cases. So thank you to all the presenters.
Thank you very much for this invitation. It was great to participate, and it's nice because it's not only surgical technique, it's not a recipe, it's a think tank, and we learned a lot, I think.
Yes,
thank you, Marie.
Yes, and thank you to everyone, because I think in a 1 hour session, I hope the participants appreciate that you spoke about biomechanism, classification and diagnosis, workup, and the different kind of option to treat this challenging fracture. So I mean, I'm learned again watching you. So thank you very much, and thank you, Guillaume.
Thanks, everyone. Thanks, Terrence, for putting this together. These meetings really help us move forward, and we all learn from each other. I think that the great secret to being a good surgeon is to keep on chatting with your friends.
Thank you, Orbay. I completely echo your thoughts. I mean, this is a platform for learning, especially with all these legends here. We had a nice session, enjoyed learning. As it's not a recipe, it's a think tank. Well said, Professor Herzberg. And the more stress towards the osteocomplex ligament, as Professor Greg said, that it's not the fracture, it's not the ligament injury, it's a combination. That's a very good and important carry-home message to all of us. And Simon, thank you very much for organizing this webinar, and we wish you safe and healthy at this juncture. Thank you all. I think we'll keep some time for Orbay to sleep. Let him have a good sleep. Thank you all.
Exactly.
Yeah.
Well, and thank you for coming, and thank you for organising.
Thank you.
Great day.
Thank you.